All right, so our next speakers are Professor Denis Velakoulis and Dr. Dhamidhu Eratne, and in Melbourne. So Denis and Dhamma are neuropsychiatrists based at the Neuropsychiatry Institute, Royal Melbourne Hospital. And they both have clinical and research hats within neuropsychiatry. Neuropsychiatry is the bridge between neurology and psychiatry, and it's to provide a multidisciplinary approach to the diagnosis, assessment, and treatment of patients with complex neuropsychiatric conditions. And approximately 40% of referrals to neuropsychiatric patients will be diagnosed with a younger onset dementia, including frontotemporal dementia. So Denis and Dhamma, the floor is yours. Thank you very much.
Thanks, Olivier. Thanks to both you and Clement for starting today off so well. I've realised that listening to both of you that it's very well coordinated with our talk. Before Dhamma and I begin, I'd like to acknowledge the traditional owners of the land on which the Royal Melbourne Hospital is located, the Wurundjeri people of the Kulin Nation. I'm going to talk for the first 10 minutes or so, and then Dhamma will talk. Dhamma has control of the slides, so I will be asking him to move them along as we speak. A brief outline for the talk. We're going to talk a bit about the symptoms which lead to a diagnosis of frontotemporal dementia and why those symptoms don't necessarily always lead directly to a diagnosis. We know that the diagnosis of frontotemporal dementia can be delayed, and that's because the symptoms are not always specifically, though, point to a diagnosis of FTD. Along the way, we'll talk about the reasons it takes so long to make the diagnosis, and also touch on some of the overlap with psychiatric symptoms and mental health issues. Dhamma will then talk about some of the steps to diagnosis and what investigations and tests are required. Thanks, Dhamma. Often it's not unusual to hear in retrospect, once we've seen patients and their families, to hear that early on in the piece they were told they're too young to have dementia, you're not forgetful, it's stress, are you sure, it could be something else. It's very common that we hear this story having seen people and made the diagnosis. On the other hand, there are explanations for this, and I'll try and touch on those as we go through. So the early symptoms, as Olivier has also flagged with us, involve behaviour, personality, emotions, and judgment. What I'll do is walk through the criteria for frontotemporal dementia and discuss each of the criteria or the main symptoms, and then try and help people understand how they overlap with other problems or mental health issues that people may have, which makes the diagnosis more difficult. Thanks, Dhamma. There are many causes for changes in behaviour, personality, emotions and judgment, not just FTD, and they could be psychiatric or they could be neurological. Thanks, Dhamma. I think it's fair to say that the commonest causes of changes in adults who first go to a GP with some of these symptoms are not frontotemporal dementia. The commonest causes are often mental health issues or other psychiatric issues, or maybe even medical or neurological conditions. So FTD is not necessarily the first thing that a general practitioner, for example, will think of if someone who's in their 40s or 50s comes along with problems with personality change or behaviour change. Thanks, Dhamma. The diagnostic criteria for frontotemporal dementia include the symptoms, cognitive testing, and then investigations. There are three categories. Thanks, Dhamma. Sorry. There are three categories of diagnosis, and this can sometimes be quite confusing for people who are not familiar with the criteria, because we use terms like possible, probable, and definite. And I know my team certainly gotten into difficulties when we write NDIS applications, for example, and say there's a possible diagnosis of FTD, and people at the other end often think, well, it's not definite, so you don't have FTD. But there are formal criteria, and the possible diagnosis comes when the symptoms and the cognitive testing point to FTD. Probable includes brain scans, and then definite includes whether there's a mutation or pathology. Thanks, Dharma. So to some of the symptoms, there are the behavioural symptoms, so people acting inappropriately socially, or becoming a bit more coarse or rude or impulsive or careless. There are explanations for this that are not related to frontotemporal dementia. So these symptoms could be associated with alcohol or drugs, psychiatric illnesses, relationship, or midlife crisis, to coin a sort of a popular term. Thanks, Dharma. Apathy or inertia, we know, is one of the more difficult aspects of frontotemporal dementia. Lack of drive and lack of interest in things. Now, again, depression can often lead to apathy or inertia, and it's not uncommon that people who end up with a diagnosis of frontotemporal dementia will have been diagnosed with depression on the basis of lack of drive and lack of interest. Thanks, Dharma. Loss of sympathy or empathy, the ability to put yourself in other people's shoes, is a common symptom of frontotemporal dementia, and one of the criteria symptom. But again, it can be seen in people who've been using a lot of alcohol or other substances. It can be seen when people are having relationship and other issues, and people will who are having marital or relationship problems can interpret their partner's lack of interest or sympathy, etc., and describe a lack of empathy on their partner's part. So it's not just a symptom of frontotemporal dementia. Okay, next. Perseverative or repetitive behaviours. Now, some of them can obviously be quite abnormal and not within the normal spectrum of what we're used to, but there are a number of repetitive behaviours that people may well just describe to habits. Oh yeah, we heard Dad saying the same, using the same couple of words all the time, but we thought it was just a habit he picked up. Or it could be diagnosed as obsessive compulsive disorder, where people do have repetitive and compulsive behaviours. Thanks, Dharma. Hyperorality and dietary changes, we know, is often a telltale symptom of frontotemporal dementia, but eating more, using more alcohol, or smoking more cigarettes is not necessarily just a symptom of frontotemporal dementia. Binge eating on sweets or Coca-Cola, etc., may not necessarily just be a symptom of frontotemporal dementia. Putting things that are inedible into your mouth, that's probably a more telltale sign, though. Thanks, Dharma. When we come to the neuropsychology and brain imaging, even though neuropsychology and imaging can be very sensitive tests, we still come up with abnormalities in other conditions like depression or schizophrenia. So we can see brain changes in people with schizophrenia and bipolar disorder, and particularly involving frontal and temporal lobes. So having those changes on a scan does not necessarily mean that you have FTD, particularly if there are symptoms of schizophrenia or bipolar disorder in the present as well. Thanks, Dharma. We know that there can be a very long diagnostic delay, up to 3.5 years, because people, the symptoms of FTD are diagnosed as something else. We know that a previous psychiatric diagnosis is very common, and that the younger the onset, the longer the delay. Thanks, Dharma. 3.5 years is clearly a long time for things to happen: relationship, family issues, employment, financial decisions. A lot of things can happen in 3.5 years, which is why it's so important to reduce that delay. Thanks, Dharma. Very briefly, psychotic symptoms or symptoms that look like a schizophrenia can be seen in the lead up to some types of frontotemporal dementia. In 40% of patients who have the type of frontotemporal dementia caused by a mutation in the C9orf gene. Thanks, Dharma. I'm now handing on to Dharma, who's going to do the second half, which will focus on some of the investigations and the way we think about diagnosis. Thanks, Dharma.
To the cardinal sin of not unmuting. Thank you, Dennis, and thank you to the organisers and everyone for the fantastic talks this morning from Sydney, and Wendy and everyone for organising. So now I'd like to give you a bit of a flavour of some of the people that we see, and I'm sure this story that you'll hear is familiar to many of you in terms of your loved ones or personal, or people that you see in your clinical practice as well, just to highlight some of the challenges and why we've still got a long way to go to improve our early and timely and accurate diagnosis. So Kate was a 45-year-old woman who was referred to our service. She had a history. She's a high-functioning, working in the finance industry, mother of 2 young children. And her story started really initially with stress at work and just not being able to manage the deadlines and pressures of work that probably had gone up a little bit, but not as much. And certainly she found that these are things that 5 or 10 years previous to this, she would have coped pretty well with. In the context of this stress, she had some trouble with her mood, some low mood and insomnia and trouble falling asleep. And she was initially diagnosed and treated for depression in the context of this work stress. Then she started to develop some other symptoms. She became very fixated and was called an obsession with a Hollywood actor, and to the point of writing repeatedly to him and emailing him and things like that, and started to bring up other questions of what was going on for her. Was this depression? Was this something else? And she saw initially in general practice and then a multitude of specialists, including psychiatry and neurology. And while this continued, it had significant implications for her and her family. That really caused a great deal of stress for the family. The husband and other family members became estranged, and certainly the marriage broke up in the context of really her symptoms getting worse and really struggling to understand what it was all about. And certainly for young children at school, it raised all kinds of questions and difficulties and stress for them as well. And then over the next 3 years prior to seeing us, despite multiple treatments for depression and her other kinds of symptoms, she continued to get worse, and she was referred to us. And I'll come back to her case once I talk a little bit about sort of the journey that people can go through. So as you've heard from Dennis and others, that the symptoms that Kate had and the symptoms that many people, particularly with the behavioral variant of frontotemporal dementia, have a long list of possible causes. And frontotemporal dementia certainly is one of them, and certainly psychiatric disorders, and probably of many of the dementias, by the very nature of the symptoms involved in behavioral variant frontotemporal dementia, as Dennis has talked about, really overlap from a clinical and symptoms point of view, but also from brain structures and networks with many psychiatric disorders. But there's a long list of other general medical or neurological conditions, many which are treatable and reversible, that need to be thought about and can present with symptoms and changes in behavior and personality and cognition, memory, language, and so on. And this is the process of going through the diagnosis, is going through a multitude of different ways of looking at the clinical presentation and brain functioning to make this diagnosis. And it certainly is a process. None of these, the conditions that have a single blood test, unfortunately, that can just quickly tell you exactly what's going on. And so this is the importance then of the history, the clinical and physical neurological examination, the utility of a multidisciplinary team. We've heard a little bit about the complementary roles of neurology, cognitive neurology, psychiatry and neuropsychiatry, neuropsychology, allied health, occupational therapy, speech pathology, as we'll hear a bit more, to try and sift through the complexity of each individual person and family's history and situation. And then there are the additional blood tests and other tests, including brain scans, genetic tests. And certainly, as you're getting a sense of, it's a process and it takes time, and there's lots of ups and downs, can be lots of ups and downs along the way. So the current state of affairs is that the history is still incredibly important. And a lot of what we're going through in the history in our clinic is trying to understand and trying to pick out, are there any red flags that would point us towards what, in a general practice setting, is still a rare disorder compared to the much more common depression, for example, or even bipolar disorder. And what are some of the red flags? The age at onset of the symptoms, particularly if it's an unusual or a later onset over the age of 40, for example. If it's a really rapid progression, if people they might have some of the symptoms, say, of depression, but not the full, don't meet the diagnostic criteria for depression. Things are progressing quite rapidly. The past history, is this a long history of a primary psychiatric illness, or this is a sudden change? Is someone who's never had history, and this is a very new presentation later on in life? Is there family history of unusual or late onset psychiatric illness, or even suicide, or history of neurological or cognitive disorders like frontotemporal dementia or motor neuron disease? What are the other medical symptoms and medications and things like that? And are there any red flags on the physical and neurological examination that would point you away from the what you'd be expecting to see in depression or bipolar disorder? So are there Parkinson's-like symptoms, stiffness or tremors, abnormal movements, problems with eye movements, for example? So then moving on to the further tests to confirm the diagnosis, many of the blood tests are to not necessarily say this is frontotemporal dementia, but to rule out other kinds of other conditions that could be mimicking it, like thyroid dysfunction, just as one example. Cognitive and neuropsychological tests to have more in-depth understanding of cognitive strengths and weaknesses, and to the profile, and to map that onto the profile you'd be expected to see in frontotemporal dementia or other disorders. Brain scans like MRI scans to look at the shape and size and structure of the brain, and if there's other pathology like strokes or tumors or masses that could mimic the presentation of frontotemporal dementia. And then functional imaging like SPECT and PET scans that look at the perfusion or metabolic activity of the brain to get you a sense of how the brain's working. Are there areas that are underactive? And then, as you've heard from Clem's excellent talk about genetic testing and the promises and the challenges with that, and in terms of access and funding and things like that as well. So coming back to Kate, as you remember, she had this history of just continuing to get worse despite multiple treatments for depression and other psychiatric symptoms. And the history really unfolded in that she developed worsening and new symptoms, becoming very much more impulsive, loss of empathy, and really completely unable to work. And it started off with a dramatic change in her food preferences, really preferring sweet foods, but then progressing to the point of putting inedible objects into her mouth. And what we initially thought of as sort of mannerisms and stress-related, just little sort of fidgetiness, became much more obviously stereotypies and repetitive abnormal movements. And certainly by this time, her cognitive profile on even just bedside cognitive testing demonstrated severe executive dysfunction and frontal and temporal atrophy or loss of volume and underactivity on MRI and SPECT imaging. So meeting the diagnostic criteria for probable BVFTD. So I was very mindful when you put your talk into, and you've got this list that it can look like, that the process follows in this nice linear timeline, and A plus B equals C, this and this and this. And what we know is, and as Dennis alluded to, the diagnostic delay, and certainly what's used in the literature in genetics a lot, but highly relevant to disorders like frontotemporal dementia, is the Diagnostic Odyssey, where for many years, and this is a picture that is an example of someone we've seen in our clinic, and not uncommon, and I think would ring a bell with many of you in the audience and speakers in their clinical care and health professionals, of people going through multiple investigations, multiple specialists, often with misdiagnosis, with diagnostic uncertainty, great degree of healthcare costs as well, but most importantly, really negative outcomes for people with symptoms, their families, young children, and so forth. So we've got, despite great advances, we've still got a long way to go to really improve and reduce this diagnostic odyssey and improve outcomes for everyone. In the future, there's lots of promise. There's a significant, as we're seeing today, I think, and in this whole day, there are these excellent, incredible teams and multidisciplinary international collaborations that are working so hard on improving this from all different angles, from understanding the basic biology and the genetics to understanding how to help and improve symptoms and quality of life. And as we've heard from Clem, there have been significant advances. The C9 or F72 gene association in 2012, I think, is a significant advance, and that continues to advance rapidly. There are new technologies like types of scans looking at tau. There's a very recent development of a blood test that could promises great diagnostic potential for just being a blood test for Alzheimer's disease. And as I'm sure we'll hear more in Dr. Rebecca Ahmed's talk about research, and certainly our group and many others in the world are looking at biomarkers like neurofilament light that's showing a great promise as a blood test to help distinguish frontotemporal dementia from primary psychiatric illness, which is, as we've heard so far, is a very challenging and common clinical dilemma. So to conclude our talk, the symptoms of FTD, there's a great degree of overlap with many other disorders, including primary psychiatric disorders. Making the diagnosis, therefore, can be tricky and can be associated with a complex and difficult and traumatic diagnostic odyssey. The history, the clinical examination, and multiple tests are required to rule in and rule out differential diagnosis and reach the diagnosis of frontotemporal dementia. And the utility of a multidisciplinary input, particularly for complex presentations where the expertise of neuropsychiatry, for example, and neurology can come together to help with these challenging situations. And it's a rapidly developing field, and there are many promises for the future. Thank you very much. That's the end of my bit, and I'll hand over back to Dennis. Thank you.
Thanks. Thank you, Dharma. And also thank you to our large and wonderful team, particularly Wendy, who's done so much work to help set up today. I think it might be time for questions. Thanks, Meryl.
Thanks, Dennis and Dharma. That was an excellent talk. So we have a question here. Is diabetes a risk factor for FTD?
Not that I'm aware of, Meryl. It can certainly work the other way, that people with FTD, particularly if people are eating lots of sweets, overweight, etc., may develop diabetes, but I'm not aware of any link the other way.
Thanks, Dennis. And would you both mind explaining what are some of the psychiatric symptoms that occur in semantic dementia versus PNFA, progressive nuclear palsy?
Thanks, Meryl. I did see that question. I've had a chat with Wendy. That'll be covered in Wendy's talk, which is coming up next. So stay tuned.
Thanks, Dennis. And do you think there's any link between the long-term use of antidepressants and frontotemporal dementia?
Again, none that I'm aware of in terms of the antidepressant use causing dementia. I'm not aware of any evidence to that effect.
Okay, and we have another question from the audience. How do I cope with my friends and family not accepting the diagnosis of FTD? They, along with my husband, who has FTD, thinks it's fine as he appears very normal at times.
Yes. Dharma, do you want to?
Yes, thank you. That's an excellent question, and it's something we see a lot in our clinic. and can be really, really challenging. And certainly in my genetics work as well, this applies to people's sort of understanding and willingness to look at sort of genetic causes as well. So it can be really quite a complicated issue. I think one of the things we often talk about in the clinic is just everyone, it's sort of like with coming to terms and coming to a sense of adjustment to anything, and, the principles of stages of grief and things like that can apply, and everyone can go through different stages and different times. And there's so many variables that come into it. And particularly, it's one of those things, if you could say, right, this is the blood test that says that sugars are elevated, you've got diabetes and things like that. But it applies even to illnesses like Alzheimer's disease, but for frontotemporal dementia, where there can be this overlap with symptoms of depression and other disorders, and they may have been given diagnoses, there can be variability of fluctuations as well. And people, their symptoms are modulated by their environment. So we often see that in some families where they say, when so-and-so is staying with me, I don't see any of these problems. And it can be really, really quite difficult. And one of the things that can be helpful is, the utility of the neutral service, where one of the things we're commonly doing is having family meetings where we try to get everyone into the same room, and often that can be really quite tricky and can get really heated. But to disseminate and share information, and often coming from this from us, and I'm not saying it just happens. It's not like you have this one meeting, but over time, and part of ongoing services that provide ongoing care is a big part of what we do. Is this journey along with families. So it certainly can be very difficult. I think we'll hear a little bit about some from Wendy and Dana and others about some of the more specific strategies, but certainly something that we grapple with very frequently and happens to a lot of families.